Good evening, everyone. As the first was saying, this is a very important topic and exactly a bit confusing also. Um, so, in the exam, the expectation is that they will be giving you a s- picture of a rotum and they will be asking you about your interpretation or your management plan. So in this session for next half an hour, we'll be talking about ROTEM. So I'll just go ahead a little bit of basics of ROTEM so that you guys will be acquainted with what does it mean and if you are given a scenario, how to interpret it. So ROTEM stands for rotational thromboelastometry. It is a point of care therapy directed information on coagulation. The aim for ROTEM is to optimize the transfusion of blood products. And also in clinical studies, it has shown that it has reduced the transfusion requirement and transfusion associated complication. Now, real time and graphical, that's what you get in a ROTEM. It gives you an idea about the clot, that is the time of formation of clot, the strength of the clot, and how does it gets breakdown or broken down. So it's not only about one phase of the coagulation, it is a holistic representation of the coagulation at different phases at different times. So how does it is carried out usually? So the whole blood is taken and it's put into a cuvette with calcium in it, and a pin, which is you can see here, is suspended into that cuvette and it starts to spin. The pin rotates gently back and forth in the liquid blood. Initially there is no resistance, but as the blood starts to clot, there is an increased resistance there in the cuvette, and that modifies the movement of the pin, giving you a particular shape of the curve, which is we call it as a temogram or the ROTEM curve. Now there are different curves that we look at based on the reagent used in the cuvette. Usually there are four or five specific curves that is represented in that figure. So first of all, the first one is called as the FIFTEM, which is fibrinogen oriented. So in FIFTEM, you get more idea about the fibrinogen as the factor of coagulation. The second is called as the XTEM. It represents the extrinsic pathway of the coagulation. The third one is a INTEM, which represents the intrinsic path of the coagulation. Um, the fourth one is called as EPTEM, which is representative of a situation where aprotonin is added into the blood to enhance or to decrease the clot fibrinolysis. And the last one is a heptem, which looks at the effect of heparin by putting heparinase into the system so that it breaks down the heparin in the blood. And whatever you see is the representation of the current coagulation status of the blood. So there are five channels we say. First of one is the FIBTEM or fibrinogen oriented channel, XTEM or extrinsic pathway, INTEM is intrinsic pathway, EPTEM is more looking at the fibrinolysis component of that. You add a aprotonin into the blood. And the fifth one is the heptem or heparin channel, where you neutralize the effect of heparin by putting heparinase into the blood. So five channels, okay. Um, Now, a little bit of theory that you need to understand, because the clot formation or the whole process of coagulation is divided into majorly three phenomena. One is a initiation, amplification, and propagation. Between amplification and propagation, the phase of fibrin formation happens. So the initiation happens with the tissue factor, which is the main starting point for the coagulation, or it is a procoagulant factor. Tissue factor exposed to the blood causes factor 7 activation, which produce small amount of thrombin. This is followed by the amplification where platelets and cofactors are activated, and hence other factors get also activated, and there is platelet aggregation, and there is propagation of the clot afterwards with a common pathway. Um, so the theoretical part of the coagulation is usually we read as two different pathways, but it's not as simple as in this. The in vivo mechanism is pretty complicated, but for our easy understanding, we think it is an intrinsic pathway and there is an extrinsic pathway which converge together for a common pathway. In the common pathway, sorry, in the common pathway, you have the factors 2, 5, and 10. In the intrinsic pathway, you have factor 8, 9, 11, and 12. And in extrinsic pathway, you have majority factor 7. So the common pathway leads to formation of fibrinogen and then fibrin clot. So this is the usual concept of coagulation that you guys know. Um, Now, the most important factor in the whole of the coagulation system is the fibrinogen. It is the most prevalent clotting factor and the final clotting factor in the common pathway, as we discussed. Interestingly, fibrinogen is consumed the fastest when the clot is activated. So fibrinogen is the first factor to fall critically low, uh, becomes critically low in a patient who is bleeding or hemorrhaging, because the body uses up the fibrinogen, and the first factor that decreases in such a situation is your fibrinogen. The fibrinogen levels are usually higher in pregnancy because pregnancy leads to delivery of the baby and there is high chance of bleeding. So as a preventive mechanism from the nature, we have a higher fibrinogen. This is the only coagulation factor which is higher in pregnancy. Now, early fibrinogen replacement assists rapid correction of coagulopathy and reduces transfusion of other blood products. This has been proven with multiple clinical trials also. Sometimes they ask you what are the sources of fibrinogen in clinical practice. So usually there are three important sources: fibrinogen concentrate, the highest amount of fibrinogen you find there, followed by cryoprecipitate, a little bit low, and if it is a apheretic cryoprecipitate, the concentration is slightly high. The least you find in a fresh frozen plasma. Now, the major coagulation determinants in major hemorrhage are the coagulation factor for sure, but there are other things that determine the patients whether they are bleeding, not bleeding, whether they will continue to bleed or not. Apart from the coagulation factor, there are other factors are very, very important which cannot be measured by your ROTEM. So you need to know what are the things that cannot be measured by this point of care coagulation test. First of all, hypothermia is a major barrier for coagulation. If the patient is hypothermic, then the coagulation whole cycle gets delayed and the patient continue to bleed. So optimization of the temperature. Unfortunately, the ROTEM system measures all the coagulation factor, and studies happen at room temperature. The patient's blood may not be at room temperature, so it may not represent the exact problem that is going on if the patient is hypothermic. Second is hypocalcemia. In this test, calcium is added to the sample, thus correcting for platelets for patients with hypocalcemia. So you cannot evaluate a patient with hypocalcemia that the bleeding disorder is because of hypocalcemia. That's the problem of ROTEM, because calcium is added into the blood and it is corrected. So you will not be able to know whether hypocalcemia is one of the cause for bleeding for that patient. It is not useful if the patient is on therapeutic, or it is not useful for monitoring of therapeutic efficacy of anticoagulants such as heparin, low molecular weight heparin, pentasaccharides, nanoparod, or anticoagulants which have direct thrombin inhibitor or the NOACs. It is not useful because it is not a quantitative value saying that um, the patient is more coagulopathic or less coagulopathic if they are on anticoagulants. If the patient is on a platelet inhibitor, they will not tell you with ROTEM. So ROTEM is useless if the patient has ongoing platelet inhibitors such as clopidogrel, aspirin, or a GP2B3A inhibitor. Patients with uremia, patients with von Willebrand's disease, you cannot find an abnormality with ROTEM. Again, platelet dysfunction, functional issue with the platelet may not be appreciable with ROTEM. So these are the drawbacks or limitation of ROTEM. And also patients who are acidemic, also in those cases, acidemia is one of the varicose triad thing that prevents coagulation to happen. So this system cannot determine whether the patient has acidemia causing coagulation issues. So these are the limiting factors or limitation of ROTEM or point of care coagulation testing. So you need to know about this. This is a usually asked question in the exam. They will be asking what are the things or what are the coagulation abnormality that a ROTEM cannot detect for you. Now, there are two types of ROTEM where one checks with or without heparin. So if the patient, if you have cardiothoracic working in a cardiothoracic unit, so you may have a machine which uses a cartridge for heparin or has an additional channel of heptin. It is called as the complete plus hep channel. So this is a different channel. So there are two different cartridge for two different result to find. So the first one is usual FIPTEM, EXTEM, INTEM, and APTEM. Instead of APTEM, in a patient who is heparinized, you may need this channel. So it is called as the complete plus hep. So FIPTEM, EXTEM, INTEM, and HEPTEM. So you look at heparin effect in this type of cartridge. The bottom one, this type of cartridge, but the top one does not give you a heparin effect. So if the patient is on heparin or is being anticoagulated with heparin, then you have to choose this cartridge and use this. And if the patient is not on heparin, then you have to use this cartridge or use this interpretation. So this is all technical things. So whatever cartridge or what machine you use, depending on that, it varies. Now going into a detail of the ROTEM. So first of all, I told you about a temogram or a fraction or one fraction of the diagram is called as the extem. It represents the extrinsic pathway. It contains the tissue factor and other factors for coagulation. It assesses the combined effect of fibrinogen and platelet. Just be careful what I'm talking about. This is very important. The extem looks at both platelet and fibrinogen, right? Both platelet and fibrinogen. It's not only one thing, okay? Abnormal clotting times are used to determine if there is a clotting factor administration requirement. So it also looks at clotting factor deficiency. So fibrinogen, platelets, and clotting factor. Three things can be seen here, okay? The next one is FIPTEM or fibrinogen channel. So the FIPTEM channel contains the same reagent as EXTEM, but in addition to that, it inhibits the platelets. So the platelet effects are neutralized here, and whatever you see in this channel is because of fibrinogen. So FIPTEM looks at the effect of fibrinogen. So if the FIPTEM channel is within normal range, then you need to look at the difference between FIPTEM and the EXTEM, because as I said, the EXTEM measures both fibrinogen and platelet. The FIPTEM measures only the platelet effect. So if this is normal, the FIPTEM is normal, where the platelet function is neutralized, and you find abnormal EXTEM here, that means the fibrinogen is normal, but the abnormality is because of the platelet. Do I make sense? So in the FIPTEM channel, whatever you see is because of fibrinogen problem. Then platelets are totally neutralized. So there is no platelet effect that can be seen. whatever abnormality you find is fibrinogen issue. If this is normal and the extem is abnormal, that means fibrinogen is normal in the blood. The abnormality in the extem is because of the platelet. So that's how you delineate. If the extem is abnormal but the fibtem is normal, then the problem is because of platelet. All right. There's a question in the chat box. Can you go to the previous slide, extem? Yes, we can. Close. Sorry. Yeah. So explaining again, this is the extem channel. So it looks at both the effect of fibrinogen and platelet. So whatever you see here is the combined effect of fibrinogen and platelet. In the fib10, whatever you see is because of fibrinogen. So if the patient has a normal fibrinogen and an abnormal platelet, then your extem channel will be abnormal. If the patient has normal platelet but abnormal fibrinogen, then both extem and fibtem channel will be abnormal, because this channel looks at only fibrinogen and this channel looks at both fibrinogen and platelet. All right. Intem, the intem channel assesses the intrinsic pathway. So abnormal clotting time in this channel are used to detect heparin effect, like APTT, similar type of thing. So if there is abnormality here, it is because of heparin effect, or it can also used to be look at protamine excess. It may also, because anything that is abnormal, that causes a abnormal intrinsic pathway it will be shown in this channel. So whether it is heparin, whether it is protamine excess, whether it is clotting factor deficiency, whether it is a fibrin polymerization disorder, or any other anticoagulant affecting the intrinsic pathway, you will find a abnormal intent. Okay, intrinsic pathway problem, right? Now, why I'm saying protamine excess and heparin effect, I discussed about that, or I asked a question in the group earlier about this. We will take it later. The last channel is the heptem. So as I said earlier, what happens is in heptem we neutralize the heparin. So whatever effect of heparin is totally taken care of. And whatever you see is totally because of other things than heparin. Okay. So suppose somebody is on heparin, then the the intem channel, the clotting time will be very prolonged because of heparin effect. But that effect will be corrected in heptem, because you have neutralized the heparin. You have totally discarded the heparin effect. So whatever is there in heptem is not because of heparin. It is because of something else, right? So if you have a prolonged clotting time in intem which gets corrected in heptem, that means it is heparin effect. But if you have a prolonged clotting time in intem and also heptem, it is not because of heparin, it is because of something else, some other inhibitors. Okay, so that's what you need to understand. So the heptem channel contains heparinase, it destroys the heparin. So this channel demonstrates heparin effect via an improved clotting time when compared to the intem channel. So in intem you will find a heparin effect, in heptem you will not find a heparin effect. If this occurs, then protamine is indicated, like if the clotting time is prolonged here in the intem and it gets corrected in the heptem, that means there is a heparin excess and you need to neutralize the heparin with the protamine. So you give protamine to that. If extensity, so remember extem, the channel here, if the extensity is normal, that means your platelet and possibly the fibrinogen are normal, but the intem and heptem city are prolonged. So the intem city is prolonged, the heptem city is prolonged, but the extem city is normal. That means the patient has protamine excess. Okay. So normal city in extem, abnormal in intem, and heptem means you have protamine excess. So the question that I asked in the group earlier, how do you determine a protamine excess? So for protein in excess, what will happen is your clotting time is normal in the extem, but it's abnormal in both intem and heptem. Now, how is it different from other inhibitors? So if there is other inhibitors present except heparin, the clotting time will be prolonged in all the channels 1, 2, and 3. All the three will be prolonged. But if it is protamine excess, then both intem and heptem are prolonged with a normal extem. Okay. Hope that makes sense. We'll go to some examples and that will make it a bit clearer. Now the parts of aerotum. So initially you looked at the clotting time or CT. This green part is the CT or clotting time in seconds. So it represents the initiation phase, that is the time from start of measurement until initiation of clotting. So you started measurement here, this is 0 time, and the length of that is the clotting time. If it is more, that means the clotting time is more. If it is less, the clotting time is less. So it represents the time for clot initiation, thrombin formation, and startup clot polymerization. So prolonged CT causes the causes for prolonged CTs are clotting factor deficiency, heparin effect. We talked about that, and you have to see how do you know which is because of what. So heparin effect will be corrected in heptem, but if it is due to any clotting factor deficiency, it will be not corrected in the heptem. We look at alpha angle. So alpha angle represents your what do you call clot initiation or clot strength. The higher the angle, the better it is. The lower the angle, the worse it is. Okay. Clot formation time. So clot formation time is clot formation time in second, which represents the pink part. So when you have, this is a time initiation of clotting like 2 millimeter, where the height is 2 millimeter until the clot formness goes to 20 millimeters. So that part is the clot formation time from 2 millimeter to 20 millimeter there. So that duration is called as the CFT or clot formation time. Again, it represents the fibrin polymerization, stabilization of clot with platelet in factor 13. If there is a deficiency, then the CFT will be prolonged. Usually, it's not clinically important. We don't look at the CFT usually. Next, maximum clot formness. This represents a millimeter height. So it represents how strong or how firm is the clot, and increasing stabilization of clot by polymerization of fibrin and platelets and factor 13. So that MCF will be low if you have deficiency of fibrin or factor 13. Okay. Now, important thing to look for is the A5. So it represents the clot firmness at 5 minutes post clotting. So if you start clotting here, 5 minutes post clotting, what is the clot firmness? What is the height? All right. So that represents the A5. This is an important number. So A5 we look at FIB10. So A5 represents the clot initiation or initial firmness of the clot. Okay. I'll go to in detail in subsequent slide. Then you look for maximum lysis. So percentage reduction in clot formation at a particular time. We usually look at 1 hour or 45 minutes, right? So reduction in clot formness after maximum clot formation. This is the maximum clot formation, and we look at a particular time. How much is the clot lysis? Okay. Stability of the clot. If maximum lysis is less than 5% at the measurement time, this is normal. But if the ml is more than 5% at or within 1 hour, then it is a sign of fibrinolysis. Massive fibrinolysis can result in a long CT or clot formation time and or a small or absent disappearing A5 or A10 in all channels except heptem, because in heptem you give aprotonyine, which neutralizes the fibrinolysis. So that's how you know. So in heptem, if the times are getting corrected, but rest of the rest of the places it is abnormal, then it is a fibrinolysis issue. Now for prerequisite, the thing that you remember clinically is you don't treat the graft, you treat the patient. If the patient is not bleeding, you don't have to do a rotum and you don't have to treat it. But first and foremost thing is to optimize the basic needs for coagulation that we talked about, because rotem is very dependent on these, and it is measured at a normal condition where the temperature is body temperature, pH is normal, calcium is normal, and hemoglobin is normal. So you have to ensure that the patient is normothermic, pH is more than 7.2, normal ionized calcium, and preferably hemoglobin of 70. And then only you send the sample for a rotum, because all these are determining factor of coagulation and will affect the result of coagulation, but you will not be able to assess them through rotum. Okay, now interpretation. So first step, what you do is to check for a heparin excess. If the patient is on heparin infusion or the patient is on a CP bypass, suppose in between CP bypass the anesthetist come with a sample of blood to see in those cases. So what happens is, in heparin excess you will have a in-tem clotting time more than 205, but this gets corrected in heptem. So the clotting time will be higher in in-tem, but it gets corrected in heptem. What does that mean? Is heparin excess. So what will you do is to give protamine just to reverse it, right? The second step is you assess always fibrinogen. As I said, this is the most important stage, and fibrinogen is the most important and earliest factor that gets depleted during bleeding. So you have to first assess the fibrinogen. Depending on what machine you are using and what setup you are in, there is a particular algorithm that we go. But in my setting, where we look at FIPTEM A5 or at 5 minutes, what's the FIPTEM height? If it is less than 9 millimeter, that means the patient is deficient in fibrinogen. As I said, FIPTEM looks at the fibrinogen. So that's the first thing you look for. If it is less than 9 millimeter, that means there is a fibrinogen deficiency. You need to give cryoprecipitate or fibrinogen concentrate to treat. So this is the first step you have to do. First step is the assessment of fibrinogen, or first, if the patient is on heparin, you have to rule it out. And the next step is to assessment of the fibrinogen. Then the next step is looking at platelet function. As I said, platelet function is assessed in two different channels. One is a FIPTEM, the other one is a XTEM. But in FIPTEM, we neutralize the platelet and we look at only fibrinogen effect. If the clotting time is high both in FIPTEM and XTEM, you know that it may be due to fibrinogen or due to platelet or both. But if the FIPTEM clotting time is if the FIPTEM is normal and XTEM is abnormal, that means there is a problem of platelet. Okay, so that's what it is. FIPTEM A5 is normal, more than 9, but the XTEM A5 is less than 35, which is abnormal, or FIPTEM is low and the XTEM is low. Both are low, or FIPTEM is normal but the XTEM are low. That means there is a platelet deficiency. Okay, you need platelet transfusion. Next step is to look for other factors. Okay, factor deficiency. But the prerequisite is first you have to correct the fibrinogen. If you don't look for fibrinogen and correct it, then most of the channels will be abnormal and you will not be able to find the real reason for that. So you have to first look for the FIPTEM channel, correct the fibrinogen, and then go next step. Okay. So the fourth step, as I said, is to assess the factors. In this case, the FIPTEM the FIPTEM A5 will be more than 9, that is normal, and the XTEM CT is more than 90, which is abnormal. Okay, you have corrected the fibrinogen, but still the XTEM CT is still prolonged. That means your platelet is corrected, your FIPTEM is your fibrinogen corrected, but still you have a coagulopathy, which is because of the coagulation factors. So you give FFPs or prothrombinics. The last thing that you look for is SS fibrinolysis. Like if straight away, if the FIB-10 is more than 600 seconds, then this is a massive early fibrinolysis. It is happening in the early stages. So you have to give tranexamic acid, or in the curve, if the maximal clot lysis is more than 5%, then you suspect it's a fibrinolysis. It may be a bit confusing talking about this, but people who have used it, it will be very easy to look for, right? These are all numbers that you get in the report. When I go to the example, it will be more easier. Okay, now let's start. I need this to be a little bit interactive, and people need to answer, otherwise it will be very monotonous and I cannot gauge how people are, what they get out of it. Okay, so that's the first, sorry, that's the first example. What do you see? Any takers quickly? So we have 10 examples. We'll go quickly. All right, someone, last slide, please. All right. I'm not going to discuss if nobody is going to answer. Abnormal FIB-10, which is not abnormal, as you can see. A5 is normal, 15, it's not abnormal. Yes, fibrinogen deficient, sorry. Okay. Fibrinogen deficiency, protamine excess, abnormal FIB-10, abnormal XTEM CT need, yep. DOACs, you cannot assess the effect of DOAC. CT prolonged, normal FIB-10, fibrinogen deficiency, normal. Okay, let's do this step by step. All right, first one. So FIB-10. So as I said, FIB-10 shows the contribution of the fibrinogen. Platelets are neutralized in this channel. We discussed about that. Sorry. So in this case, the fibrinogen or FIB-10 A5 is normal. It's 15. So that's normal. Okay. So there's no issue with the fibrinogen here. Next channel that we see is the XTEM. So what do we know about XTEM? XTEM looks at platelet and clotting factor, including fibrinogen. Okay. Now in this case, the CT is prolonged to 110, indicates possible clotting factor deficiency because the fibrinogen is normal here, and either it is a platelet issue or a clotting factor issue. Now, platelet contribution is the difference in A5 between XTEM and FIB-10. So look at XTEM is A5 is 36 or 35, and here is 15, and the difference is more than 20, which is pretty good. Okay, so the extra effect of platelet in excess of fibrinogen is from 15 to 36, which is 20. Okay, which is acceptable. So probably the platelet functions are good. So no issues with platelet. Now go to INTEM. What happens with INTEM is the clotting time is prolonged. So this means in the absence of heparin, because this patient probably is not heparinized, this channel is not necessary to guide transfusion product. But when you look at EPTEM, oops, sorry, it shows the clot stability, but compare the XTEM with the EPTEM and maximum clot lysis determining the fibrinolysis. So here the clot lysis is 0%, so no fibrinolysis happening. So EPTEM is used for fibrinolysis. The major effect here is either it is because of a problem of platelet, which we think less likely, or it is a problem of coagulation factor. Okay, because the XTEM and the INTEM, both the clotting, the CT is prolonged. So it is an issue with the coagulation factor. So in that case, how do you treat it? You give fresh frozen plasma or prothrombin. So basically, how you evaluate is first step, fibrinogen 15, which is normal. A5, we look at the A5 normal, so it is not a fibrinogen issue. Go to extem, the CT is prolonged. The CT is prolonged can be due to either fibrinogen or clotting factor or platelet, but we know that the fibrinogen is normal, so it is a problem with clotting factor or platelet. Now, because the A515 here and the A5 is 36 here, there is a quite a good amount of contribution from the platelet. So probably platelet is not the problem. It is possibly the clotting factor. The second or third step that you look for is the intem. The clotting time both in intem and extem are prolonged. That means it is a coagulation factor issue which you will treat with FFP. The aptem is used to look for clot lysis. If there is no clot lysis, then that's what is your diagnosis. The patient needs FFPs. Okay. Now, second one, let's talk about this. What's happening here? Can you take us quickly? Okay. Somebody says, Venkata Ganesh says fibrinogen deficiency, fibrinogen deficiency, fibrinogen deficiency, A5 is less. Yes. I think now it makes sense. I hope people who are answering can see. Now the A5 here is 7, which is marginal, like 5 to 20. So it is less, probably less, because I showed you that graph earlier, the table or the arrow mark, that we look at a A5 of around 7 as the minimum or 8 is the minimum. If it is 7, then we are in trouble. Okay. So you have a 15 which is less than 8 or 7. That means there is a problem with fibrinogen. We know that already. Okay. Next step is extem. Now it is very hard to see the effect here because the fibrinogen is already deranged. So interpreting anything in extem, intem or aptem will be difficult because you have to correct the fibrinogen first and then look for the platelet effect. Okay. So in this case, what will you do is to transfuse fibrinogen to the patient. Okay. The only extra information that you can get in aptem is the maximum lysis, but it is 1%. So anything more than 5% is abnormal. 1%, so there is no increased fibrinolysis. So how will you treat it? You will supplement the fibrinogen here. Okay. Because with other channels, will not be able to interpret anything as long as you have a fibrinogen deficiency. Okay, so fibrinogen concentrate will give or cryoprecipitate. Depending on that, you can supplement pool of platelet because you are not sure whether it is because of platelet and fibrinogen or just fibrinogen, just to make things a bit more problematic. So you can see this A5 is 7 and in the extem A5 is 17. So rise in the A5 is only 10, which may also be an indicator of platelet deficiency. So you need around 20 increase from that to there. A5 should increase from 7 to 27 to say that the platelets are adequate and it's only fibrinogen. Because the increase is around 10, so it's not too high. But again, this is just a rough estimate. It's very hard to see how much platelet are contributing to this abnormality, as long as you have to correct the fibrinogen first. But again, we sometimes look at the difference. Difference is not too high. That means there is a contribution to platelets also. Okay. This one, any takers? So 35-year-old woman, gravida 5, para 4, suffers a PPH with hemodynamic instability, taken to theater for intervention. What products will you advise? So A5 is 10 here. Usually in pregnant patient, we want an A5 around 11. So if it is 10, probably it is a fibrinogen deficiency. In XTEM, the A5 is pretty robust. Can you see 45? So 10 goes to 45. So good platelet function. But the problem is with fibrinogen. So what will you do again? Transfuse fibrinogen for obstetric bleeding. So just keep in mind the obstetric cutoff for A5 in most of the centers are more. So you need a higher A5 for obstetric bleeding. So at least by 2. So in normal patient who are bleeding, we look for A5 or 7 or more, but for obstetric it is 9 or 11. Okay, so slightly higher. Okay, right. Let's go to the next one. Any takers for this? The clotting time is 4059 in the 15 and you don't have anything in the 15, just like a straight line again. So this is the usual thing that you see, all right? So it is a fibrinogen deficiency again. So I'm showing a lot of fibrinogen deficiency because it is very common, okay? So the way you can find a fibrinogen deficiency, one is A5 will be totally gone. There is no A5. The other one will be a clotting time high. And this can also be present if there is a hyperfibrinolysis. So there is no fibrinogen and the clotting time is very deranged and you will get a maximal clot lysis more than 5% here. But this one doesn't have a ml of 5% or more. So this is probably only fibrinogen deficiency. Okay, got it? Early fibrinolysis, you can see that. So you again supplement fibrinogen in this case. What is this one? Quick, quick. What is this one? This one. Somebody has pointed. What does that mean? 100%. So again, fibrinolysis. How will you treat is any answer? How will you treat this? Tranexamic acid, right? Correct. Okay. Now next. 60-year-old woman who was admitted with subarachnoid hemorrhage is less responsive after sudden gush of blood into the EVD. How would you proceed? That's her ROTEM interpreted. Again, clotting time. These are all practical cases. So very, very, very high. What's happening with the ML here? 99%, 6% in EPTIM. Okay. Again, fibrinolysis, tranexamic acid. What's happening with this one? Can you take us quickly? So 15 A5 is normal. Okay, what does it say? Factor 7. Okay, factor 7 deficiency. I cannot make out what is factor 7 deficiency, right? We talked about this. Now in TEM, what is happening? The clotting time is abnormal. It gets corrected in HEPTEM. Okay, what does that mean is the patient has heparin on board, right? The INTEM, which is completely abnormal, gets corrected in HEPTEM. That means there is a heparin effect. So you give ROTEM to this patient. Okay. This one 56-year-old man post reduced sternotomy for AVR and cabbage. Drain output is 400 ml in first hour. What are the next steps in patient care? Okay, what's happening here? Again, just look at the star ones. So in lysis is 9%. So again, there is increased lysis. Though it looks fat and wide, but you have a clot lysis of 9% and the patient is bleeding. So what will you do? Tranexamic acid. All right. Okay. This one, we talked about this already. So in TEM, the clotting time is 1500, which is abnormal. In HepTem, it gets corrected 138. So what is this? Heparin effect. Okay. So what will you do? Give protamine. Very common in the exam. Okay. What is this one? This is important one. Now see this bottom line here. I'll just point out what is there. So in the INTEM, the clotting time is 268. In the HepTem, the clotting time is 369. Okay. Both are prolonged. And in the XTEM, the clotting time is normal. We talked about this combination already. What is this? Yes, it's protamine excess. So what will happen? You'll have a prolonged time in INTEM and HepTem. XTEM is normal, so you have given protamine in excess amount. So protamine in excess amount is a anticoagulant. Okay, so in excessive protamine use, you will have INTEM and HepTem prolonged, but normal XTEM. Okay, all right. I think this was the last example, I believe. Yep. Thank you. Thanks a lot for your patient hearing. And if you have any questions, I'm happy to answer. Otherwise, I will hand over to Tapas, who will be talking about the next session or whoever the speaker is. Thank you. What
Hello.
about what about other numbers? Uh, Previous two slides answers. We discussed about that already, didn't we? So this is the question. You mean this one? So this is the heparin excess because you have your clotting time is high in the INTEM, that gets better in the HepTem. So that means if you put heparinase, the clotting time gets normal. That means there is heparin excess. So that's the one, and the previous one before that is this. So this looks normal except for the clot lysis, maximum lysis ml. So 9%, which is more than 5%. That means the patient has ongoing fibrinolysis. You give tranexamic acid. Okay. Hope that makes sense.
Yeah, Dr. Hamid, we will be sharing the recorded session soon after editing. So just bear with us for the editing purpose. But please attend it live and hopefully this would be more useful to you.
Somebody has told Tapas that in my EDIC exam I could not see any number. I just saw pick and guess what happening. Okay, so you need to know the what do you call the structure of the champagne glass. Okay, you just Google on the you can Google it and see ROTEM champagne glass format. So there are two or three things that you need to know. We talked about that already. So this is the usual. Even if you don't see the numbers, it's pretty self-explanatory. Like I'll show you. This one is fibrinolysis. As you can see, a flat line in the 15. So you don't have to have anything there. Okay. Even if the no number, you can see this is fibrinolysis or fibrin deficiency. This is again late fibrinolysis. You can see this type of what do you call picture. This is late fibrinolysis. Then this one, the first one here again a straight line. Same fibrin deficiency or fibrinolysis or early fibrinolysis. Um, This one again, you have a narrow FibTem, so that means there is fibrin deficiency. So you need to know what channel you need to see and what are the abnormalities. Just Google some pictures. You'll be well acquainted with that. Sometimes you may not find the numbers.
I have that. If you like, I can share. Just
Yeah.
1 second. Yeah, I will be showing you. Is it visible?
Not yet. Yes, now you can see it.
Yes. Yeah, Sanant, you can go through this one and explain if the candidates expect any answers. But I think after your so elaborate discussion, the candidates would be now more clear about the structure, how to approach, and also this is the different champagne bottle, the glass, and you can how you can guess what is happening. So this is the common ROTEM patterns. This is brandy snifter. This is the
That's the
normal
normal
format.
one.
Yeah.
Then
Then the
if you have factor deficiency, your clotting time will be prolonged, as you can see here, before it goes up. So this is the clotting time is prolonged, the stem of the champagne glass. Fibrinogen deficiency, in that case, your A5. So A5 is low, 5 minutes, A5 will be low. Okay. So in that case, you have to give fibrinogen again. Thrombocytopenia, again, I mean, I told you about, so this is going parallel, it doesn't go up like this. Can you see how it goes up in the wine glass, in the brandy? It goes up in a tangent with a good alpha angle. If the alpha angle is not good and it goes parallel, then it is a thrombocytopenia. Okay. Fibrinolysis, as you can see, it is narrowing down. So inverted Martini glass. So it's easy to remember if you can see these curves, but practically you need to have numbers also. I don't know what will you get in EDIC exam, but you may get it without the numbers, and they can give you that also.